And I'd like to welcome Lloyd McKenzie. Lloyd, take it away.
All right, hello and welcome. So this is the session on burden reduction. We're going to give you a quick overview of three different Da Vinci implementation guides, CRD, DTR, and PAS. We love three-letter acronyms. My focus is going to be on the first of those, so CRD, and I'm going to pass it on to others to talk about the other two. CRD, coverage requirements discovery. The same outline we're going to follow pretty much for all three IGs. We're going to talk to you a little bit about what the purpose of the implementation guide is, what workflows it's trying to cover, examine the different FIRA resources that are involved, what are the operations that are part of addressing that workflow, and then what the conformance expectations are. We will pause for questions after we talk about each IG. So do capture your questions as we go, and then we'll hopefully have a bit of time at the very end to talk about the big picture and general questions and anything that you think of as you're listening to the rest. The problem that CRD specifically is trying to address is that the payer community often has information that is relevant to the decisions that clinicians need to make. So when a clinician is just seeing a patient for the first time, or is writing an order, or scheduling an appointment, or making a referral, there are things that payers know that would be really handy if the providers knew at the time that they were making the decisions. And if we did that well, we could reduce the amount of work for the providers, reduce the amount of work and general running back and forth that we often enforce on patients and their caregivers, just by making sure that the right information is available at the right time. The primary use case for CRD ties into coverage requirements. So I'm about to do something. Are there special coverage requirements related to that thing that I, as a clinician, am about to do that I should know about? So is there a need for prior authorization? Do I need to try drug A before I can get drug B covered? Do I need to have special documentation that I capture in my system to meet audit requirements and payer expectations? But above and beyond that, there are other types of information that the payer might choose to share. So for example, this particular medication isn't covered, this other one is, that's more or less equivalent, would you like to switch? Or this one, they're both covered, but this one's going to cost the patient $200 a month, and this one's going to cost them $30. Maybe take that into account in making your prescribing decision. Or hospital XYZ already did an X-ray on that particular part of the patient's anatomy last week. Maybe you want to go and see if you can get access to that as opposed to ordering a brand new one. So there's lots of places where payers may have information that clinicians don't, either because the payer knows the rules and the clinical systems often don't have that awareness, especially if the rules change based on context of the patient. But also the payers are often engaging with a broader set of the healthcare community and may have even clinical information from sources that the particular clinic or hospital might not have access to. Coverage requirements discovery fits into a broader set of functionality, which we call in Da Vinci burden reduction. So there's three implementation guides. The first one that manifests for the clinicians is coverage requirements discovery. And that is as you are prescribing, as you are making a referral, as you are doing something in your EHR, we use CDS hooks to pop up a little card that says, hey, here's something you might want to know. And that's designed to be not terribly obtrusive, but is done in a way that clinicians can glance at it, decide if they care, and possibly engage with it to go get other information or to prompt a change to whatever it is that they're doing. Following that, we have DTR, which lets us convey in easily computable form what it is that a clinician needs to do to meet coverage requirements. So what forms do they need to fill out? What information do they need to have in their EHR? And sort of quickly and automatically assess or gather that information so that that capturing of information is done as quickly as possible. And that if you've already got the information on hand, that we don't tell you, hey, you need to go gather this stuff because you've already got it, and maybe we can automatically fill in the form for you and minimize that effort. And then finally, where prior authorization is required, PAS gives us that ability to actually make the prior authorization request. X12 by regulation needs to be in the middle, but PAS gives us the ability to do that over FHIR. So the three sort of tie into each other in that CDS hooks allows you to identify that, hey, there's additional requirements or prior authorization is necessary, and then tie you into the smart app that's going to guide you through gathering the relevant information. And then once that information is gathered, PAS lets you submit that prior authorization request and get back a response. So CRD lets you do other things. It's not only about prior authorization and coverage requirements. You can just communicate cost of medication, or hey, here's the prescribing guidelines that this payer has for this particular medication. So just conveying information, but in terms of the broad theme of burden reduction, we tie into the other IGs in that manner. The rest of the presentation is going to focus just on that first step, though, which is coverage requirements discovery. This is a good page to take a picture of with your smartphone. You should also be able to download the slides. And these are all of the links that you need to know in order to make use of CRD. So the official home for the CRD spec, where we will post the official STU version, which should be coming out in just, well, it'll be locked down in a week or two. We'll have a couple of hoops to jump through before it becomes official publication, but that's happening soon. But in the meantime, you can take a look at the continuous integration build. Right now, the official home just contains the ballot version. We've made some changes based on ballots since then. This week and forever into the future, if you are implementing CRD and have questions about the spec, questions about implementation, just want to discuss with other people who are participating in the Connectathon, there is a stream on chat.phir.org specific to CRD, where those questions can be asked and you'll get hopefully timely answers. There's a general Confluence page that talks about the specification and gives you information about our conference calls. You can go take a look at past minutes, see some of the decisions that we've made and why. And if you basically want to engage with the project, that's the way to do it. And then finally, all of the feedback that we have about the specification comes to us through JIRA. That's how HL7 tracks requests for change and questions. And so if you want to get a sense of what are some of the changes that are outstanding, or what are some of the changes that people have asked for, and what's the discussion been about them, all of that can be found in a implementation guide specific dashboard, and that's available there. I'm going to quickly give you an overview of the implementation guide. And just drag that over onto the screen that you can see to just give you a sense of how this implementation guide is set up. It's not huge. It shouldn't take you more than a couple of hours to go through the whole thing from top to bottom. This is the home page, just sort of gives you an overview of what the specification includes. You can navigate that either using the home page or the table of contents or this main menu here. So the specification has some use cases and overviews. So what is CRD trying to do and what are some of the different ways that can fit into your system? There's a technical background page that covers things like what is fire and what are the things that you need to be aware of coming into this if you don't necessarily have a lot of previous experience with fire implementation guides. However, all of the guts of the specification are here. This is a pretty long page, but all of the conformance expectations, all of the shall, shoulds, mays are on this one page, one-stop shop. If you want to print it out and read it on the bus or something, you can. Or airplane, not that anybody's traveling anywhere these days. And it talks about things we're going to talk about more in this presentation, about how to implement fire. There's a set of downloads. So if you want to download a copy of the spec, or if you want to download the examples or whatever, you can do that here. And then credits if you care about who wrote it. There's also a page on artifacts. And the overview is probably where you want to start. We draw from US core specification, and there's a bunch of profiles that we leverage from that. And we also define a number of artifacts specifically within this implementation guide. So if you want to go see what are the artifacts that we've produced, this is how you do that. And there's some guidance in terms of what are the different types of artifacts that we're going to be explaining to you. In CRD, we've got some additional search parameters to meet our requirements. We've got a number of profiles on resources that are of interest to this particular implementation guide. We've defined extensions in a couple of places, defined terminologies, and then there's a bunch of examples. And that's really the implementation guide. You can also go take a look at the underlying fire spec. We rely on Fire Release 4. We also tie to US core. We make heavy use of CDS hooks, and we make use of SMART. So it's sort of a one-stop shop for everything that you need to get to that is related to CRD specification. Going back to our slides, there's really only two systems at play in the CDS hook or in the CRD specification. We've got our provider application, typically in EHR, and that is the system that is making the decisions. So they are deciding to order a drug or order a lab test or make a referral or discharge a patient or book an appointment or just take a look at the patient record. Whatever it is that they're wanting to do, it's something that could theoretically be something that a payer has useful information to share about. And the second system is either the payer system or the payer agent. It's possible that it might be a third-party system that the payer provides access to relevant information. And with that, that's all we need for the flow. A given payer may have multiple decision support systems. And of course, EHRs can have multiple systems as well. So you might have one system for ordering labs and a different system for ordering drugs. We don't necessarily care about that. All that matters is that there's a clinical system that needs to get information, decision support information from a payer system. In terms of the FHIR specification, the only real part of FHIR that we're making use of is the REST API. We're doing search to get access to information from the clinical space. the specification that we exercise most heavily is CDS hooks. And the notion with CDS hooks is that at some point where a end user is making a decision, we fire a hook off to a service. The service says, hey, there's useful information that we can provide, and passes back cards. And those cards might just contain information, or they might contain a link to a smart app, for example, a DTR smart app. The overall workflow is that the provider does something in their EMR based on a clinical activity, or the provider says, I have a question about what kinds of payer information might be provided if I decided to do something like this. I'm not actually going to create a prescription. I'm going to do a what if I created a prescription. In either case, the EHR or an app fires off a request to the payer and says, do you have any useful information? The payer may then go and hit the EHR to retrieve additional information. What other labs exist? What other medications is the patient on? Grab me some demographics, whatever is necessary to decide what advice the payer has. The payer then provides results, and sometimes those results include links to web pages or smart apps that the provider application might use. Different types of information a payer could give. So is prior authorization required? Yes or no? Are there specific requirements? For example, is there a form that you need to fill out? Or is there a smart app that you need to launch to gather relevant information? And actually providing information related to the medication, or let's consider switching the prescription. All of those are defined in the CRD specification in terms of what they should look like, and they are based on general card types available in the CDS hook spec. In terms of FHIR resources that you'll be leveraging, you'll be dealing with a whole bunch of administrative resources. So who is the patient? What is the encounter? What is the location? Who is the practitioner involved? What coverage does the patient have? What organization is the provider working for? All of those are things that can influence whether prior authorization is required, whether there are additional coverage requirements that are relevant to the process. We profiled, in addition to all of that, those infrastructure resources, we care about request resources because that's typically when you want to provide decision support, is when somebody is ordering something, be that meds or labs or making a referral or scheduling appointments, etc. We have profiles on those. We leveraged profiles from US Core and the HREX implementation guide. And most of the CRD specific profiles are really about ensuring that there is a linkage to encounter and location and practitioner and coverage everywhere, because you will get past just the request resource, and you need to have those linkages in order to be able to go and grab what is the location, what is the coverage, what is the organization, in order to make appropriate decision support guidance from the payer. In addition to that, we also have a couple of de-identified profiles, because there is a workflow where the payer wants to provide decision support, but they want to do it not based on knowledge of patient identifiable information. They just want to say, if you are dealing with a female who is in this age bracket and is covered under this plan, here is with the coverage information that you need. So prior authorization is required or not required, because none of the rules are patient specific. They're all generic based on general demographics and the type of plan that the patient has. And doing that, of course, means that you don't have the overhead of worrying about sharing protected patient information and some of the overhead that may be involved in receiving that kind of stuff. In terms of conformance, at a minimum, you need to be able to support patient and coverage, because that's the minimum that you have to have, some basic demographics and a notion of what kind of plan the patient is on. And then beyond that, you need to support at least one of the hooks and types of requests. We don't say that you have to support meds and lab and referrals and appointments. You need to be able to provide guidance on at least one thing, and you decide what that one thing is. And then depending on what it is that you're planning to provide guidance on, the profile in question, whether it's a medication request or a service request or something else, will tell you what else you need to be able to support. And then you may choose to also support additional profiles if you need to go and query into the patient record to find out other information, then obviously you'll have to support that too. In terms of terminologies, we tie into the same stuff that US Core does, so LOINC, SNOMED, RxNorm, HCPCS, that kind of stuff. It's possible that when you're querying supplemental information, you might look at some of the billing type codes. That's not likely, but it's possible. Most of that information isn't terribly queryable using existing interfaces at the moment. But all of that is defined in US Core and HREX. We don't really define a heck of a lot of terminology in FHIR. In terms of the technologies that you'll be leveraging, CDS Hooks is the primary focus. You'll be using REST search to go and query additional EHR information if necessary. And you'll be using SMART to trigger what-if scenarios. And also, if one of the cards comes back and says, hey, look at the SMART app, then that will be there as well. There's a number of security and privacy considerations listed in the specification, so do take a look at those. Yes, I'm going fast because we've got to cover 3 IGs in only an hour. In terms of conformance, we don't use conformance statements in CRD because there's no support for CDS hooks in conformance statement yet. That may change over time. And so long as you support at least one hook, you're good. In terms of the cards that come back, you need to be able to at least support the instructions and external reference cards. The others are all optional, so being able to invoke a smart app is not something you have to be able to do, although if you intend to support DTR as well, then that's going to be important to you. Reference implementations, we've got a generic CDS hook client. There is a payer service and also an EHR service, so you can see how all of those work. And all of those are hosted at the Logica Health site, which is where we host most of our reference implementations. There is a set of test cases for CDS hooks. When you're logged into Touchstone, you will have to click in the top right where it says FHIR and switch that to say CDS hooks. Because by default, you see all of the FHIR ones and you don't see the CDS hook ones to do that. And you do have to log on to see those, but that's all available to you. In terms of what's going to be happening over the next few days, certainly encourage you to experiment with the reference implementations to get a sense of how CDS hooks works and get a sense of what are the kinds of things you might be able to do with it. Certainly think about it from a prior authorization perspective, but also think about it beyond that. And do come and join us on our calls. We have a call from 3 to 4 Eastern on Fridays where we talk about all of the burden reduction specs. So come in and hang out and ask your questions there. And we're going to talk about the agenda for the Connectathon this week at the end. So that is DTR. So pause for a couple of questions while we transition who is presenting. Any questions raised thus far?
Lloyd, I do not see any questions posted currently.
All right. So either everything is crystal clear or everybody is totally confused. We'll find out tomorrow which of those is true. You've got my email, and you've also got the link to Zulip, so feel free to ask questions there at any point.
Thanks, Lloyd. This is Larry DeSells with MITRE. We're, as Lloyd mentioned, we're going over 3 IGs. It's going to be fairly quick pace this morning because we only have 1 hour. I'm going to go over the what's called the Documentation Templates and Rules IG. It's kind of a companion IG to the IG that Lloyd just went over, CRD, Coverage Requirements Discovery. And as I get into this presentation, hopefully you'll understand how they kind of work together. So we're going to talk about some of a little bit of, just touch on the history, how it started out, a little bit of the background of the folks that are sponsors and work groups, go over some of the DTR workflows, go over some of the fire resources, and some of the key technologies, key fire technologies that the DTR IG uses. So this is right out of the DTR IG document templates and rules. We affectionately call it DTR, implementation guide, or IG, specifies how payer rules can be executed in a provider context to ensure that documentation requirements are met. So it's a way to bring what the actual rules to the provider environment. So it doesn't have to be run that way, but that's how this current IG talks about the DTR process. So again, these are the work groups. So DTR, IG, and RI are part of the HL7 Clinical Decision Support Work Group. It's an HL7 accelerator, the Da Vinci accelerator. It's a use case within there. Currently sponsored, this IG and RI development is sponsored by CMS, and it's implemented by the MITRE Corporation. So Lloyd had a similar slide. Some of the key roles here are the healthcare provider EHR. In this role, a provider wishes to discover the documentation requirements, as well as have the documentation, as well as have the template pre-populated to satisfy documentation requirements. And then the healthcare payer, in this role, the payer examines the request for documentation templates and rules and responds appropriately. This could be used as the server part of the transaction. So this is this kind of, as I mentioned before, CRD and DTR are kind of companion IGs. This essentially is a slide that shows the two of them working together. On the left is the provider EHR environment. The clinician may order a durable medical equipment, DME, might order a service like home health therapy, or a medication. And what they're going to do within their EHR, they're going to trigger a CDS hook, which is they're going to actually send a CDS hook via their client to the payer on the right, which would be hosting the CDS service, which is what Lloyd had just talked about. This CDS service will look into a repository of rules and determine if documentation is required. Now, it also can return whether or not prior auth is required. So it can do either or. It's not dependent on prior auth, but it can do both. So for example, it can return and say there's documentation and there's prior auth. And in some cases, for example, in CMS, not all of their, for example, DME require prior auth. Some just require appropriate documentation. So what will happen is this arrow down here, number 3, will go and return a hook back to the client. The EHR will be presented with a card. That card will have a link. That link will launch a smart app. That smart app will when it launches, will call out to the repository of rules. It'll pull CQL rules and questionnaires, and it will pre-populate this template. Then moving along, any gaps that may exist or other questions in the questionnaire or template will be manually populated. And then once that's finished, it will be stored back to the medical record in the EHR. At this point, you could also send what's called a questionnaire response to a payer or any ancillary service. So this drills down a little bit into the DTR process. And one thing that we've started calling the DTR process, we've started calling it the DTR process in the newer version of the IG. The first version was very specific to SMART, but it doesn't have to be implemented as a SMART app. It could be implemented, for example, in with native code within the EHR. So just to go over this workflow, a clinician might want to order DME, for example, or a service or medication. They would, assuming that CDS call they made to the CRD service said that documentation was required. The Smart App would launch. The Smart App is contained in this kind of box here. And again, there's a little note here. It could be a native application, so it doesn't have to be smart, but something would launch, and it would call out to the backend payer service, payer server, which would be the repository, as I showed before in the previous slide. It would retrieve CQL files. It would retrieve Firebase questionnaires, and it would run a CQL engine, and it would pre-populate the questionnaire. And there's a sample questionnaire here, name, and you can't really, apologize, you can't see it all, but down here would be specific coverage requirements and based on conditions. So this form is actually quite large, and tomorrow when we give a demo of this reference implementation, you'll be able to see it in its entirety. Again, the clinician would fill any gaps. That questionnaire response would go back to the EHR Fire server. And again, at this point, you could send that questionnaire response to payer for prior auth or some other service. So just to touch on some of the profiling that some of the profiles that DTR has. We've profiled 3 different resources. If you're familiar with Fire, a profile is kind of based on a resource. So in this case, we have a profile called DTR questionnaire, and this just illustrates some of the mandatory fields or mandatory elements, some of the prohibited elements that we've profiled. If you were a new developer or this was a new project that someone, maybe your company asked you to work on, these are some things that you would probably jump in and okay, make sure you have these required fields as you start developing this. And just to illustrate, this is just a basic graphic. It starts out, we're basing everything here on a questionnaire resource. The DTR questionnaire itself is a profile of the CQF questionnaire, so it's kind of a third profile there. So the first is a resource, and the next 2 are profiles of those resources, and so on. The other kind of a resource that we have profiled is the DTR questionnaire response. So there's a questionnaire, and then there's a response. So this has all your answers to whatever questions that you had to fulfill. And this again shows prohibited elements, mandatory elements. And tomorrow we'll get into the IG a little bit more, but this is just to give you an idea of things to look for in the IG, as far as this is a differential table and shows you required fields and whatnot. And again, another graphic. This is not as nested, if you will. We've profiled the questionnaire response, which is not actually, is just, it's just a resource that we profile. And then the last profile that currently is used in DTR is task. So it's DTR task, and again, some mandatory elements. It does have 1 fixed element. And this graphic shows we've just simply profiled. So when we say profiling, for those who aren't as familiar with FHIR, it's kind of like setting constraints with a current kind of a data structure, if you will. Okay, so this just talks about some of the resources and profiles that we're using. We do, as Lloyd said, similar to CRD, we're based on US Core and HREX. The HREX, I've added a couple, and by the way, all the links in this deck, and the folks attending today will have access to this deck. All the links in this deck are live, and so these HREX links actually are from the IG, and they point to a decision point tree within HREX to talk about some of the technology and some of the decisions that were made there. Terminologies, value sets. The DTR IG does not define value sets. But where we do use value sets are within the rule sets. So we call rule sets the combination of CQL and the questionnaire. And that's not a term that's in the IG. It's just a term that within the RI we reference CQL and questionnaire in that. And so again, the current RI rule sets use value sets currently defined in VSAC. It doesn't have to be VSAC. We just chose to do that or to use that because essentially that's what VSAC's for. And we use some HL7 value sets, for example, administrative gender. Most of the value sets will need to be defined by the EHR implementer unless an abstraction is used in order to use different value sets. For example, if a payer wanted a different value set for qualifying conditions for home oxygen therapy than the ones used by the DTR RI, then a value set identifier could be provided as an input parameter. And I can get into that more tomorrow. I know that's probably a little much for some folks, but we can, when we go through these IGs and RIs tomorrow, I can get into that a little bit more about what that means. And then the payer should be the steward or publisher since they are the ones who define the rules, the services, conditions they care about. As far as code systems, it's a mix of intentional and extensional value sets. If the underlying code system is SNOMED, CT, or ICD-10 CM, they're intentionally defined. Otherwise, they're extensionally defined. And then we have the current code systems we use: SNOMED, as I said up top, RX Norm, LOINC, HCPCS, and ICD-10. Must support, we do not mark any elements as must support, but because we do reference US Core, the second sentence here, this IG references US Core IG, the Da Vinci DTR implementations shall conform to US Core IG must support guidance. So we're essentially just calling out that, remember that we use US Core in our must support statement. FHIR technologies, privacy, safety, security. This is just a few links. They basically reference other web pages as far as all those areas, and I won't go through those right now, but we're certainly happy to go through those tomorrow. Again, some technologies. FHIR R4, specifically version 4.01, as I said earlier, US Core, Smart on FHIR. And again, these are all live links, so you can click right through this. And as Lloyd mentioned, CRD, our current CRD has the CDS hooks order sign hook implemented. We actually had about 3 or 4 implemented, but they CDS hooks deprecated 2 of them. So that's actually a newer hook, order sign. And then of course, CQL. So little verbiage for those who aren't familiar with some of the verbiage in some of these IGs. Shall, an absolute requirement for all implementations. Shall not, an absolute prohibition, prohibition against inclusion for all implementations. And then there's should and should not, and then there's may. Just to give you an idea, when you read these guides, what each one means, shall means essentially if you're going to conform to this IG, you essentially have to implement that. As far as conformance statement, we don't actually have any conformance statement in DTR, but there are some conformance language because we do use a lot of shalls, a lot of shoulds. So to me, working with us for a couple of years, CQL and the fire questionnaires shall be required even in the event the payer is not acting as unique all payer smart on fire app. So what we're saying here is, for example, from every now and then at a Connectathon, someone might ask me, do I need to support CQL? And the answer is you don't have to, but you won't be conforming to this IG. So if you want to conform to the IG, you would want to implement CQL in the fire questionnaires. And then, and that's where I kind of get into, and then there's a lot of other, probably too many to go over in the short period of time today. We can certainly talk about this tomorrow. There's certainly other shall, should conformance statements in the IG. As far as links, these are some links. Again, these are live links. The current status of IG is we're hoping to get into STU1, but while STU1 reconciliation is complete, STU1 we're supposed to go to STU1 in the fall soon, fall 2020. Next ballot will be May of 2021, which we ballot for STU2. And then again, I've got some links to the implementation guide, the GitHub repository, and the Da Vinci use cases. Lloyd has a similar screen with other links. These are also live links. Testing resources. Lloyd already talked about the CRD testing. The Smart App, we use Aegis Touchstone within Da Vinci. They don't, early on, they did not have support for a Smart App, but they just recently, I think a few months ago, added support. So that's something that's in the queue to get going. And then putting it all together, if you want to get involved with the project, become familiar with the IGs that we've been talking about and all the technologies, read up as much as you can. We meet twice a week currently on Wednesdays, 11 a.m. Eastern time, and then Fridays, 3 p.m. Eastern time. And again, these are live links, so you can go and add this to your calendar if you want. And then if you want to, as Lloyd mentioned, there's Zulip. We encourage folks to ask questions on Zulip. The great thing about Zulip is if you ask your question there, it's, there's a history and someone else can actually search and maybe find an answer before they have to post and whatnot. And there could be a nice open dialogue for others. And again, these links are also live links. And that's about it. So next we're gonna have Gary Gryan show us, walk through the PASS IG or prior auth support IG.
Thanks, Larry. So I'm Gary Gryan. I'm a principal data analyst with the MITRE Corporation. I'm leading the team building the prior authorization support reference implementation. I'm going to give you a roughly 20-minute overview of the PASS IG and a brief introduction to the reference implementation. That's a lot of material to cover in 20 minutes, but don't worry, we're going to have an educational session tomorrow from 1 to 4, where we will have deeper coverage of the material and an opportunity to have a Q&A session with the engineers building the reference implementation. Next slide. This is just a quick overview of what we're going to cover today. Next slide. Here's the introduction. Next slide. Why prior authorization? So the primary motivation for this IG is to reduce the burden on the actors in the healthcare system. And by actors, I mean providers, payers, EHRs, or any other entities in the electronic prior authorization workflow. This has been a difficult problem to solve because there's a lot of complicated processes in prior authorization, a lot of variation, and a lot of complicated data. The purpose of these IGs is to standardize the data and the interaction among the actors and impose some structure so that we can simplify the process and standardize the data. By doing this, we believe we can really reduce delays in patient care, decrease the cost of healthcare, and reduce burden on all the actors. Quantitatively, CAQH estimates that this could save a large portion of the estimated $13.3 billion annually spent. Next slide. Key concepts. So healthcare is full of acronyms, so we need to review some of these in order to avoid confusion. FHIR is obviously Fast Healthcare Interoperability Resource, a standard for data exchange. For those of you who aren't familiar with DaVinci, DaVinci is a payer organization promoting interoperability. The process here is to create one or more IGs to solve a particular use case. The IGs specify what data to use, how to use the data, and what operations to support. As part of the maturation process, we build reference implementations to show how the problem can be solved with the IG. And in the process, we find issues with the IG, corner cases we didn't think of. We find that the data might be more complicated than we realize, or there are ambiguities that we need to address. So all of these learnings are fed back into the IG and the RI. So it's an iterative process where we create a specification, build it, test it, learn from our mistakes, and revise the specification. The cycle works best when there are a lot of people testing and implementing because they bring their specific issues and cases that might be unique to them. For electronic prior authorization, DaVinci created 3 IGs that work together but can also be used independently. These are CRD, Coverage Requirements Discovery, DTR, Document Templates and Rules, and PAS, Prior Authorization Support. Next slide. Workflows and actors. Next slide. Okay. So here we see the basic data flow among the various actors. So as Larry and Lloyd have already sort of mentioned, you have coverage requirements discovery. There's basically a request sent to ask, is prior authorization or documentation required? And it's either no, it's not, or if it is yes, then there's a smart link to return. The documentation rules, template and rules data flow is, well, if there are requirements, please send them to me. And the payer then responds by returning a FHIR questionnaire. So prior authorization support is the last one in this sort of chain of interchanges. So the DTR constructs a prior authorization claim bundle, sends that to the payer. The payer then basically takes a look at that bundle, pulls out the pieces that it needs, applies whatever rules it has, and returns a prior authorization claim response. Next slide. So here's a little bit more detailed version of the above slide. So because X12 is required under HIPAA regulations, a payer can defer this and have a clearinghouse do the FHIR to X12 interconversion. So the data flow here would be the provider submits the prior authorization claim, including a claim resource, plus all the supporting inflow. That goes to the clearinghouse, which can in turn translate that to X12. The payer can process that. The prior author, they can have their own automated decision engine that applies the set of rules. This could be in CQL or whatever methodology they want to use. And then that response is sent back through the clearinghouse to convert back to FHIR X12, and then eventually back to the provider. Or if you don't want to use a clearinghouse, you can do all that internally. Next slide. Here's a picture from the implementation guide with a little more detail. And the bottom box basically shows the scope of prior authorization support. So it's basically having to deal with all the FHIR X12 interconversion and dealing with a couple of different operations like polling and whether or not you can subscribe to see if you get the results back. Next slide. Here's another detailed diagram of the interchange between client and server in X12. So a pass request goes to the server. That's translated to what's called an X12 278. And the X12 278 response comes back. And then that completed response goes back to the client. Once that response comes back, there may be items that are independently adjudicated in the request. So it may be that the client, in this case, it might be the EHR or the provider, starts a dialogue with the server to keep checking back to see, is that request complete? Next slide. So we're going to do a quick tour of the IG. You can find it at the link right there. Next slide. We're going to go through and describe some of the fire resources that are involved in PAS. Next slide. So what's an implementation guide? So implementation guide is basically a set of documents how fire is adopted to solve a particular use case. In this case, it's solving the prior authorization use case. So these IGs are refined through connectathons and through a balloting process. So the IG is defining the fire resources that represent the data to exchange. It defines code system as value sets, and it's computable and can be validated. Next slide. So here are some of the key resources in PAS. So the basic ones are the PAS request bundle and the PAS response bundle. So the bundles are basically a container that can capture all of the information that's going back and forth. So within the request bundle, you have a claim, you have a set of request items, and they can be service requests, device requests, or medication requests. There's also an organization, a patient resource, and coverage. And then in the response, there's the claim response, also the organization, patient, and coverage. And the IG stipulates that you're not supposed to duplicate any of the resources there. So there should be a single instance of them that are referenced within the bundle. Next slide. So the basic data flow. The client submits a fire bundle with a PAS claim resource. So each of those items can be independently adjudicated. And the bundle has to contain all the fire resources to support the claim. And I think I mentioned that it's got to be no duplicates. So the PAS server returns a fire bundle with a PAS claim response. So each item can have a status of pending, approved, or denied. All the PAS resources are derived from US Core. Next slide. So because of HIPAA regulations, we have to do the Fire X12 interconversion. So X12 is a proprietary standard and requires that you have a license. If there's other supporting information, the IG allows you or recommends that you put that in a 275 unsolicited attachment. And as another thing that happens is that the IG expects the fire bundle to be included as a base 64 encoded attachment in the interchange. So there's a team currently working on the Fire X12 mappings, and the draft mappings are under review. And the expectation is that X12 will eventually publish these mappings from Fire to X12 and X12 to Fire. Of course, as a pair, you also have the option to use a clearinghouse to do the interconversion. Next slide. So security in PAS, since there's a lot of personal health information going back and forth, the PAS IG references the Atrix IG for how to implement security. So there are two currently available ways to do this, one of which is server-to-server OAuth, and a second is mutually authenticated TLS. The expectation is that the servers will implement both of them, and the clients can choose which one they want to use to talk to the server. So we'll have a little bit more detail and depth on that tomorrow. Next slide. Let's talk about some of the fire operations. So polling, what is the status of my claim? So this is this sort of, are we there yet? So when you get back a claim response, you can keep asking if certain items are not either denied, if they're still pending, you can ask what's their current status. Or you can, if you don't want to poll, you can support it. The PAS IG supports subscriptions. And there are two methods for that, REST hooks and WebSockets. It's also possible to have a dialogue where you want to do an update to an item if it's still under adjudication. So we can either do a full update where you send back the entire bundle with everything, or you can just do a differential update where you send only the parts of the request that have been changed. Next slide. So where does this fit in the whole HL7 grouping? So this is, PAS falls under the Financial Management Working Group, and they have weekly meetings that address some of the concerns. Next slide. So PAS specific profiles. Next slide. So if you go to the IG, you can see all the different operation definitions and resource profiles that are available for pass. Some of these I've already mentioned: pass claim, claim inquiry is how you're asking for things back, claim inquiry response. Next slide. These are some of the other profiles on for pass. Next slide. And some of the extensions that are defined. Next slide. Next slide, please. Sorry. So there are a number of value sets that are included. So a lot of the ones that are coming directly from DTR, LOINC, SNOMED, ICD-10. In addition, there are some other ones, the NUBC revenue codes. There are also going to be some external reference sets with X12, and that's currently being worked on by the mapping group. Next slide. So there's some example instances that are including in the IG. It's probably worth taking a look at these. I don't have time to do that right now. Next slide. More example instances. Next slide. So the core FHIR technologies that are in use for pass. So we have a REST, and that's how you interact back and forth with the server, and security, HREX using MTLS and OAuth. Next slide. Conformance and testing. Next slide. So this is an example. If you hit, so we have a FHIR, the reference implementation is up on Logica Health. If you hit the endpoint with the metadata, you get back the conformance statement, the capability statement rather. And next slide. We also have a number of, this is the same thing, but basically just going through Postman. Next slide. So the other part of testing is we have a set of test scripts that Aegis has graciously written for the pass IG. In order to access these, you need to create an account with Aegis, and you also need to be part of the Da Vinci group. Next slide. So here's how you would, here's a typical login. If you're going to use this, you need to join the HL7 FHIR domain. Next slide. And here's a brief screenshot of some of the tests that are available, and just so you can find this stuff eventually, since it's rather deeply nested, it may not be obvious how to get there. I've included that screenshot. Next slide. So let me talk a little bit about the reference implementation. Next slide. The goal is to show the IG can be implemented, define the issues or ambiguities, and it's open source, so you can download it and play with it and use it as a starting point for your own efforts. Next slide. So what's in the reference implementation? We have a lot of, it's almost all Java code. There's some great build files. We have a wiki that's extremely helpful if you're trying to understand how everything works together. We also have a Docker build. So Docker is a container system. So once you build it with Docker, you can pretty much run it on any operating system of your choice. We also have a Postman collection, which is, Postman is a very useful tool that allows you to interact with a server or even your local pass instance, so you can send stuff back and forth. You can look at what the content going back and forth is. You can see the errors. So that's very useful. We'll probably be demoing some of that tomorrow. We also have a set of unit tests in Java, and we have it integrated such that when we make a change to the GitHub repo, it automatically deploys to Logica Health. It takes about 10 to 15 minutes usually. Next slide. We also, in the Pass IG, we also have the Pass automated claim disposition. So it's basically a CQL execution engine that you can, it's not specified in the Pass IG, but it's technology that you can use to adjudicate claims. So we've done some optimization on this, including pre-compiling the CQL to Elm and some multi-threading improvements. So if you're a developer, then working with CRD, DTR, you're probably already somewhat familiar with CQL. Next slide. So you can find the reference implementation at this URL, and it's really worthwhile going through that, and because we have a lot of description about all the different operations that we support. Next slide. Yeah, this is just another thing to get the metadata endpoint. Next slide. We also have some debug endpoints in the reference implementation. So if you want to see the content that's there, you can hit the debug endpoint, say for claim, and there's also a little thing you can click so you can see the actual stuff that's going back and forth. And we found this extremely useful, so you might find it useful as well. Next slide. So putting it all together. Next slide. Connect-a-thons are a great place to learn and work with other implementers and connect with other people who have knowledge. And we also recommend several of these weekly Da Vinci burden reduction calls. So if you're getting into this and you're having questions, these are a good place to go and talk to people and bring up your issues, and we're there to help support you. Next slide. So we have more learning resources if you're how to conduct the fire IG review by Graham. We also recommend that you go to some of the previous Connect-a-thon sessions, because we've got a wealth of information. Like we have the track preparation video that shows you how to install and build the reference implementation. So, and some of the presentations that we've given at previous Connect-a-thons have a lot of really useful content. So I would highly recommend that. Next slide. So there's even more learning resources. And next slide. So tomorrow we're going to have implementation day. Next slide. So that's tomorrow from 11 to 4. We're going to have presentations on CRD, DTR, and PASS. Do some deeper dives. We'll show some of the stuff running on Logic of Health and some of the AGIS tests, and we'll have time for more questions and answers. That's all going to be hosted on the Confluence page. Next slide. This is the rough schedule of what we're going to be focusing on tomorrow, subject to change. Next slide. That's pretty much it. I'd like to thank CMS for funding and sponsoring this project, as well as my colleagues Ben Langley, Megan Riley, who've done a lot of great work in building out the reference implementation. Thank you very much.
Thank you, Gary, Larry, and Lloyd. And we've unfortunately run out of time during this session. We do have 3 questions posted in the session Q&A. So I'm going to ask that the presenters, if you could go in there and at your convenience, please answer those questions. They will remain in there, and hopefully you guys will get the answers that you need. And we will see you on the next session. Thanks so much.